Okay, good afternoon. Uh, First of all, I like any question, any concept which is emerging from our discussion last week. We were talking about arm and elbow. In the arm, we learned was that arm has a flexor compartment and it has an extensor compartment. And then we were learning about there's a group of muscle who are present in the extensor compartment and there's a group of muscle who are present in the flexor compartment. And each compartment has their main nerve. The nerve for my flexors were musculocutaneous and nerve for my extensors were the radial nerve. This is what we were learning. And then we named different muscles and then we were engaged the actions produced by those muscles on what? On my elbow joint and on my shoulder joint. Then we talk about the artery and the veins which are present by myself and my colleagues. And then we talk about the elbow joint. We discuss the bones, we talk about common fractures and the associated injuries. You are expected to be good with all these things because this MSK is all about functions, actions, and injuries. And it's all connected to the nerves and the muscle functions. And you are expected to be good with all those concepts. The collateral circulations. I hope everybody understand the concept of collateral. You talk in your language, tahwilat, the tours. If a road is blocked, how you can reach to your main destiny. So this was being discussed. We talk in detail about the injuries regarding to different plexuses. Brachial plexus was the main discussion point. For elbow joint, we talk about what are the bones who contribute. Then we talk about what are the different actions being produced by this joint. And what are its supporting ligaments and what are those stabilizing factors and which type of joint was this. So with this much info, there was a little bit left. So I'm starting from that slide. And right now you're looking at the upper end of the radius and the ulna. For your and my concern, we should be very clear. Radius should be across your radial border. Which is your radial border and my radial border away from my body. That is lateral border, where my thumb is. Thumb is my first digit. So if I put my hand in an anatomical position, this is my lateral border or the radial border of my body. And the part of my upper limb which is facing my body, that will be the medial line, medial border or the ulnar border. And that is connected to my pinky. We have to be very clear. This is the area for ulnar. This is the area for radial. So we will be connecting infos shortly and we'll be seeing it, how much meaningful is that for us. So let's start. We talk about the elbow joint. Elbow joint has three components. There's an articulation between the humerus and the ulna, humerus and the radius. And then just below to that, within the same capsule, we have an articulation between the head of the radius and notch of the ulna. And that joint is given a name of proximal. Proximal, it means it's towards my head. Proximal radio-ulnar joint. Now, I'll be going over with this joint. So now, to begin the ball rolling, what I have to show you here, so now let's label it. This bone is ulna, we are good with that, and this is the radius. Are we fine with that? And this is the head part of the radius. And then this is the, what is that? Olecranon notch. And then this is the place where we have the articulation, radius, no, radial notch for ulna. So radius has a space. Ulna has a space. So they are made for each other. That's why they are named. So ulna has a place where ulna can accommodate head of the radius. And then this is one of the ligament which has been shown up here. These are the extensions. Now, we talk about, we had an extension which wraps around. That starts from the ulna, it wraps over the head of the radius and come back to ulna. So it is basically hugging him, keeping him close to. Ulna and radius, they go close by this strap. And this strap this strap which is going over, that is called annular ligament. Are we good? And this is primarily the making point of my superior radio-ulnar joint. Now, if somebody asks me, what type of joint is this? This is a synovial type. And which type of synovial? It is my pivot. Excellent. So this is a pivot type of joint. Don't forget merry-go-round. When you were kids and I was a kid, we loved to go over in different caravans and different festivals. We love to have a ride in that. And this is the axis of the movement. The movement is across the vertical axis, longitudinal axis. So that's my axis point, and this is how we can achieve the rotation. And this rotation is giving me what movements? It gives me supination and pronation. This supination and pronation is primarily dependent on the movement occurring between radius and ulna at two places. One is on top, one is at bottom. So you're looking at the top part, that's the proximal or superior radio-ulnar joint. Right? So I have writing it something for here. And what is that? Can somebody read it for me loud? Yes?
Sudden sharp yanking of a child's forearm while conducting the child roughly onto a cliff may cause the radial head to slip out the annular ligament. This is known as a pull elbow.
Thank you. So now she was reading it, but I know majority of you are not able to listen what she was saying. So rather than, we can see it. Look at it. A very common picture. We love our child. Parents are holding their baby. But be careful. Don't do it. Because by doing that, there are fair enough chances. You might pull out the head of the radius from its place, and then it become a disaster. The head of the radius is being pulled out of this annular ligament. And look at this baby. You're walking by, and suddenly you saw a puddle. You know, baby loves to put your feet, and they like to tap in the puddle, and they don't care. Their clothes got ruined, and their shoes got ruined, but they love it. We all love it when we were kids. Now what happens? Look at his hand. After you are saving him, but you cause a sudden pull, and that resulted. Look at the hand of the baby. Look at his face, and look at his bone. What you have caused? You saved him from a puddle, but you caused him this much. That's the price. So we have to be careful. And that's a pulled out head. Are we good? So that we should know. For every action, we should know. We love to throw the babies in air in excitement. Oh, I love you. I'm showing my gratitude. But it might end up in having some kind of head injury. It's not like there is some kind of concussion. One aspect. Second, you may not hold the baby back. So a small thing which started with an excitement end up with a disaster. Don't do it. Be careful. I remember my own child, my brother was throwing her up. I said, gentlemen, hold on. You are my brother. It's okay. But it's my daughter. And there are consequences for that. I respect your love, your affection and everything, but consequences are there. So watch out. So you have to be rude at times. I'm not saying be rude, but you have to be in a polite way. Are we good so far? So now, in reality, your patient will never come and walk to you with his bone in his hand, with his arm in his hand. Patient will present to you with some kind of problem. And when you are investigating a patient, you should be expected to know each and every layer. For that sake, we have MRs and CTs. So this is a real section of a human arm. What level? We need to be good at it. And you are expected to identify, not on a CT image today, but tomorrow you have to. An MR image, you have to identify. So how I have an orientation, I should have a map that how and where I'm looking at. And then this picture tells you what level this arm is being cut. to reveal this section. And you can see inside, I started with this slide. You remember? On Thursday, I started with this slide. That was my first slide where I took a section. And this section is connected here. If I'm good with that, I can see humerus, I can see a group of muscle in front, and I can see a group of muscle behind. So now I'm sure you can identify who's who and what is what. If not, work on that. Another aspect, little down. You can see my level of section is going down. And I'm not saying learn all 1 to 16. You should be able to identify 3, 4 major structures out of that. Not everything. What is relevant? At least you can say where is biceps, where is brachialis, where is humerus bone. Nobody will be asking you what level. For that you need to grow. Are we good? Cutting further. So we are going more down. So now you can see that if you compare this image with my previous image, you are seeing that now 2 bones have started emerging. So it means ulna is also coming in the image. And there you can see my radius and ulna together, and you're looking at the joint between these 2 bones, superior or proximal radio-ulnar joint. So you will be expected to be good with these sections. And I'm sure the material which has been uploaded on the Moodle, these images are there. If not, please let me know. And you need to be good. What is the level of section? It's not about memorization. It's all about your concept. If you know in your arm, these are the muscles, then you can anticipate where this muscle ends and where this muscle begins. Okay, so we are done with that part, but we have to cover on Thursday. That now we have completed. Now we are talking about another very important landmark. Like we talk about axilla. So now we'll be talking about cubital fossa. What is this cubital fossa? The place in front of my forearm where I have these 2 epicondyles in between this aspect of my upper limb. That's the cubital fossa. So let's reveal it. The cubital fossa, skin has been removed from near the elbow, in front of the elbow joint, skin has been peeled off. So this is how it looks like when you remove the skin. We are within the superficial fascia. Membranous layer and a fatty layer. You can see these superficial veins. There's a cluster of them. I go further down, they're cleared up. Now I have cleared up the superficial fat. Now I'm close to my deeper layer. And now you can see more visible, more prominent veins has been shown up. Dr. Sadi has talked about these veins, so I need not to go in detail again. Only I can dissect further down. So you can see that now muscles, they were covered in deep fascia. So that deep fascia has been stripped at various places. You can see here. Can you see that in this image? So this is the fascia, deep fascia, which was covering this muscle. Going further, more cleared up. Veins become more visible to you. And that's the story of my cephalic and basilic vein and median cubital vein, which have been used for giving medicines, for taking blood, for, different purposes. Now, we have gone deep. We have taken away all the veins. Now we have dissected the deep fascia. Now you can see very easily, there is a very prominent tube-like structure, which goes up and down. Can you see that? This is my brachial artery. Thank you very much. And then you will see the nerves. You can see each and everything very clearly. The lower part of the biceps muscle is visible here. Are we good? And then there everything is off. You have removed the deep fascia. You can see very clearly the biceps, its lower part, it becomes like a tendon. Its epineurotic part is being shown. Everything is being shown, and this is how it's been attached. So this is where are we working? What I was showing you, cubital fossa. And now this is a schematic picture of the same cubital fossa. You can see very clearly there are 2 muscles who are making these boundaries, and these muscles, we know about them. We know about brachioradialis. And there is another muscle which we haven't known about it, but we'll be knowing about it. That muscle is my pronator teres. So this muscle name says it is for pronation. And then you can see the tendon of the biceps. That's a content. There you can see some nerves. Brachial artery, median nerve. And then radial nerve, if you pull that thing apart, then you can see it. Otherwise, the main contents of cubital fossa are the tendon of the biceps, brachial artery, and median nerve. Are we clear? So that you are expected to know. How? This is the place which I call it as cubital fossa, and then you can see that its boundaries, who's superior, who's inferior, who's medial, who's lateral, who makes the roof and who makes the floor. In the floor, we have muscles attached. We have bones. In the roof, you saw those veins, superficial veins. They are not in the content. I'm talking about a box. A box, there are certain things outside, but there are certain things inside. A box had well circumfered boundaries. So this is how you should be. You are expected to know about cubital fossa. This slide is a must-know slide. If you are asked about cubital fossa, this much info has to be very clear. Okay, so now we are looking from the back. We stripped off the skin. And there you can see how this ulnar nerve is going so close to my medial epicondyle. And that's why if you hit accidentally your elbow, you have an electric shock like feeling, and that's there. So you can see the close relationship of my ulnar nerve with the medial epicondyle of my humerus. Are we good? Okay, what do you see here? Tell me. Is it really a job of a mother? Eating her baby? So carrying it, but inside, mouth is inside? Thank you very much. This is the reality. So when you see an X-ray, if you only see one image, you can be deceived. You'll say it's fine, it's fractured, but you have to see in reality that is it really fractured? So if you are observing any X-ray and you have to give a judgment, look for two views. Don't see from one angle. Use your 3D thinking. Use your different angles, and that's important. This picture I bought for that sense. Anyways, so let's start our topic of today. Because X-rays you'll be finding a lot in our blog at different places and in your future blogs. So now today we'll be talking about the flexor muscles of the forearm. There's a compartment. We are done with the arm. We talk about almost every major concept. There are some minor concepts, but the job of this session is to share with you some major, important, and relevant infos. So now you're looking at in this image, different arms, but this picture I'm more interested. Can you see that? One part is blue and one part is brownish. So one part is front, one part is back. So today we are talking, my theme is blue, so blue goes to blue. So these are the flexors. And you can see those brownish one, which are on the other side, they are the extensors. That we will be talking in the next session. So now let's go deep in. So now we can see a hand, anyone's hand, we can see these veins if we are spending time in workouts and doing in gym, your hand can be, your veins become visible. So this is a normal human forearm. These are the bones inside, and these are different group of muscles. Guys, we use a term group of muscles. You are expected to know action on the basis of group of muscles for minor muscles. The word minor has a very broad explanation, but there are certain big major muscles. We have done those. We learn about, and here there are some major muscles, some minor muscle. So it's better you learn the action as a group, then you learn the action as an individual. It depends. So your knowledge should be back and forth, and you should be connected. So this is a sequence of my forearm. So we'll have, but you can see there are a lot of muscles here. So let's see, let's do something. So make it easy. You know, this topic it has a lot, but let's do it. Let's divide it into chunks. And these chunks, let's take one by one. Take one chunk, have a deep breath. Relax. then take the next, then take the next, you're fine. If you try to eat the whole pizza in one go, maybe you can, I don't. But if better, if you have wedges, if you have chunks of it, and you can take slowly, slowly, slowly with each bite. If you try to drink the whole glass, probably you will throw it back. So we have to take chunk by chunk. So now, before that, you can all do this. Can you do that? Show it to me, what is being shown in this image. What is the target? First of all, find your medial epicondyle. Medial epicondyle. Hold your hand. Open the fingers. Heel of your hand. Rest on the medial epicondyle. And now your fingers indicate a group of muscles. Got it? So in my forearm, on the flexor side, I have so many muscles. To make my life easy, I say they are arranged in layers. Some of them are superficial, some of them are intermediate, and some of them are deep. Your books, some of the books don't say about intermediates. They say superficial and deep. Now don't try to fit everything here. Don't bring intrinsic and extrinsics here. That's a different story. All this is a way of learning, a way of understanding. So now, by doing this, it will help you. If you forgot something, you can figure it out. So if you do it again, your index finger is indicating a very important muscle, and then this is how you learn. This pinky is on ulnar side. So you can see that pronator teres, flexor carpi radialis, because it's going to the radial side, flexor digitorum superficialis, and then I have flexor carpi ulnaris. So names, when we were talking in foundation block, I told you so many muscles. They have been classified on the basis of their functions and on the basis of their location. So all of these muscles, this medial epicondyle is a reference point. From here, almost majority of my flexors, they are coming. This is their proximal attachment. I'm talking in broad way. This is their proximal attachment side. They are coming as from one common source, and then they are splitting. One is going towards my radial side. So this is flexor compartment of the forearm, flexor carpals, because it's going to the carpal bone, flexor carpi on the radial side, flexor carpi radialis. Flexor for my digits, these are my digits. This is my pollicis, flexor digitorum superficialis. Flexor carpi ulnaris, a flexor which starts from the common flexor origin, crossing the carpal bones and going to the ulnar side. Pronator teres, a muscle who's made for bringing me pronation. Teres means superficial. Now this is another way of saying it. Guys, this is all about Latin. I'm sorry, we are not good in Latin. We have to learn it. There is a learning curve. So now, it looks difficult to you, maybe, but no, it's not that difficult. Let's make it more easy. First, I like to start from my section. This is my forearm and the skin which covers my forearm. Now, underneath, I always have superficial fascia, which is made up of a membranous layer and a fatty layer. And within that, I have two veins, cephalic and basalic. My basalic vein always towards my body, medial side. My cephalic vein is away from me, lateral side. So cephalic and basalic, these are superficial veins. And then this green ring indicates my deep fascia, which is a very thick, strong compartment which enclose all the muscle groups who are present within my forearm, both anteriorly, posteriorly, laterally, medially. So this is a strong sleeve. Let's say you are wearing a cloth. You are wearing your dress. So your sleeve is covering everything, and it's a strong piece of cloth which makes your sleeve. Are we good? So now let's put things here. We have two bones. My arm has one bone, but my forearm has two bones. And the bones are radius and ulna. Excellent. One towards my thumb is radius. One towards my pinky is ulna. Now, we have compartmentalized the stuff. a major division. You're north, I'm south. You're east, I'm west. So a demarcation which separates my flexors from extensors. So anteriorly, what do I have? I have flexors. And posteriorly, what do I have? I have extensors. Then when I use the term extensors, which joint? Extensors of what? Flexors of what? I have so many joints. I have to be very clear in my instructions. If you've been asked about something, then it has to be saying, name the flexor. What? Arm flexor. What arm flexors? You are asking flexors of the shoulder, or you are asking flexor of the forearm, flexor of the elbow. So you have to be specific about a joint for whom you are asking about a question. Maybe some muscle is flexor here, but it may be extensor here. Extensor here, maybe flexor there. So you have to be very, very careful by choosing the right words. Now, we call this compartmentalization, this septum, which divides my forearm into two broad categories, intermuscular septum, because it separates the two muscle layers, two big group of muscles. They have been separated out. So now this is in between the two bones. We call it interosseous membrane. Guys, name is a membrane, but don't get deceived. This interosseous membrane is a very strong, thick, prominent structure. It is as strong like a bone. It helps my weight transmission. It is one of the weight transmission factor. If you are just resting your whole body weight on your hands, weight transmission travels through this interosseous membrane. And interosseous membrane is the one which connects my radius and ulna. If you remember, 50 years back, when we were doing foundation block, 50 years have gone. That time, we talk about syndesmosis. And you are given an example, interosseous membrane. The membrane which is present between radius and ulna is the same thing. Now, this is my anterior compartment, obviously, which is facing me. If I'm in an anatomical position, which is in front, that is my anterior compartment. So who lives in my anterior compartment? Primarily, flexors of the wrist, digits, and pronators. Obviously, pronator of what? These two joints, proximal and distal radioulnar joints. So what type of muscles I cater here? Flexors of the wrist and flexor of the, look at my hand, flexion at the wrist, flexion at the digits, different level of flexion, right? So this is the job of those muscles. And the other job is they are pronators. We all know what is pronation and what is supination. Then who's their nerve? Their nerve is median nerve through its branches. Median nerve and its branches. Because it's a summary slide, so I just said median nerve. But please, air on. Then I have a further subdivision. Some people say, no, we are separate. We are special. Okay, who are you? So they were given a separate compartment. This is a compartment in a compartment. My anterior compartment is further compartmentalized. Where? On the ulnar side. Think, there are some clue, ulnar side. So something, ulna, ulnar, ulnaris, ulnar nerve. So this is a compartment where those structures who are primarily controlled by ulnar nerve, they are living. So these are digit 4 and 5. So digit 4 and 5. Where is this is my digit 4 and this is my digit 5. Pinky is my digit 5. My thumb is digit 1, 2, 3, 4, 5. So 4 and 5, their deep control is through ulnar nerve. If I forget everything, I can figure it out from this image. And now, their nerve is not median nerve. They are not following. They have a different plan. And their nerve is ulnar nerve. Correct? I know it's a little tricky concept, but relax. We'll talk about it. Now comes to the posterior compartment. Who lives here? Opposite to that. You are given an example in our structure of the week session, and Shahid brought this you tug of war, and you one win, one lose. This happens. So my posterior compartment, who lives here? The extensors of the wrist. In the anterior compartment were flexors of the wrist. And there were, we talk about, and then we have supinators are living here. Supinators and extensors of what? Wrist and digit. And their nerve is posterior interosseous nerve. We didn't talk about it. What the hell is this? Guys, my radial nerve, when it reaches near the elbow joint, it divides into superficial and deep. Superficial is just for the skin areas, for very little job. It don't have much of the motor component. Its deep branch is given the name of posterior because it's on the back. Interosseous, posterior to what? Interosseous membrane. That's why we call it posterior interosseous nerve. Now I'm using a term posterior interosseous. Now I have to look for, because otherwise I could have said interosseous nerve. No. When I'm using the term posterior interosseous, it means I will be having an anterior interosseous nerve also. That we will be revealing shortly. Are we clear so far? So if you understand this, you have understood the whole game plan for, like you have understood the forearm. 40% you have done. Now, remaining 60% we have to work on. Okay. So this is the deep branch of radial nerve. We talk about that. Who the hell is this posterior interosseous nerve? This is the deep branch of my radial nerve. Now, let's quickly recap these bones. I know you have done these in this week in your lab session, and Eman has explained a lot in the structure of the week session, so I'm not putting too much time. Quickly in fulls. This is a must know, guys. Sky is the limit for details. This is a must know which I'm showing you right now. You should be able to identify where is medial epicondyle, where is neck, where is head, where is notch. That's it. So now these are my different capitulum, trochlea, auricular non fossa, radius ulna, head, neck, radial tuberosity, styloid process. This is important thing. On both the bones we have it. Now, we were talking about this interosseous membrane. Are we good? Then this is the interosseous membrane. Now these are the carpals in my wrist, carpal bones. Then I have metacarpals, and these are my phalanges. We have 3, proximal, middle, distal. But my first digit has only 2. There is no middle thing there. I will take your question at the end, not now. Are we good so far? Any issue? Quickly ask what you want to ask.
So you said on the posterior compartment we have this like this supinate, and the biceps is a part of the supinator, but like it attaches in the flexor with the flexor.
I presume you're lean or not, or lean. You're lean. Wow, I can identify. So lean, your question is supinator is in the, from the name you have picked out, it is a muscle of the posterior compartment. So how this, okay, brachioradialis, a muscle who started his journey from the muscles of the arm, working and living with the muscles of the forearm, getting its food and everything with the extensor nerve for the extensor compartment, and working for flexors. So my biceps, if you look at in detail, its tendon, it goes around, it makes, that's how the supination thing will come. I haven't gone in detail with this concept, but I think I have inserted that slide in that which is visible to you. If you have any doubts, please come back to me, and your question will be answered shortly, not now. It will be covered, don't worry for that. So guys, are we good with these labels? So we know that, let me keep it there. So any problem with this? Everybody knows what is P1, P2, P3. In my first digit, I don't have P3. I have only P1 and P2. There is no P3 because there are only 2 phalanges. For rest of my digits, these are digits. You know, oh, this is a digital device. Guys, digit is what? Where you're using your finger. That's digital. Old days, it was something rotatory. Now you're touching with your finger. So that is the digitalization. Okay, guys. So now we know about the bones. Anything which is unfamiliar within this image? Perfect. So now let's start the ball rolling. We are talking about the extensor, the flexor compartment, anterior compartment of my forearm. superficial layer. I have divided into superficial, intermediate and deep layer. For what? For my better understanding. Otherwise, show me. I'll give you cadaver. Show me where is this. No. It's just for my understanding. Because there are so many muscles. So I have a muscle. You can see that it's coming from two bones. Can you see that? See it again. Coming from two bones. Who's that muscle? Guess. Pronator teres. Now, something is very important for this pronator teres. Number one, it's a pronator. It's okay. But my median nerve passes between the two heads of this pronator teres. Now, if my pronator teres has some problem, if it becomes hypertrophied, there are chances it will compress on my median nerve. And if that is happening, we call this condition as pronator syndrome. Median nerve can be entrapped, and this median nerve it can give to us pronator syndrome. Are we good? So that we need to understand. In the normal condition, there is no problem. But if this nerve, and guys, nerve doesn't need 2 million pound pressure. A slight thing, a piece of feather, if you put on a nerve, it may cause significant symptoms. Even up to loss of sensation. A nerve doesn't need too much weight, too much exertion. A little bit cause significant. Are we good? So this is the first muscle of my superficial layer. Then, can you see this great thing which I have added? This is my common flexor attachment point. Old book says common flexor's origin. So this is a common flexor attachment site, and from there most of my flexors of forearm, excellent, they are emerging. Now let's add one by one. A flexor, can you see that it's crossing my carpal bones and it's going to the radial side? Suggest a name. Flexor carpi radialis. Can we say that? Perfect. Flexor carpi radialis. Why we call him flexor carpi radialis? Because it's coming from the common flexor, present on the flexor side, crossing the carpal bones, going to the radial side. Name is flexor carpi radialis. Then there is another muscle, interesting muscle. It controls this skin of my palmar skin. It doesn't go to any bone. This muscle is called palmaris longus. How I check it? If you just make your fist and just press it here, you can see there is something visible to you. Something become visible to you on your forearm. Can you see that? If you find it, it's okay. If you don't find it, it's okay. Because around 25% people don't have it. And that muscle is not attached to the bone on this side. It's just stretching the skin here. Palmar aponeurosis, a thick skin. And this is my palmaris longus. So it may be absent. So I have done 3 muscles so far. And then look at it. This is where it's been attached to this triangle, which is present on the palmar aspect of my hand. And this has been attached. This is called palmar aponeurosis. And now, tell me the name. Flexor carpi ulnaris. And you know the reason. I need not to say it. Everybody is clear? So we have talked about the superficial layer. Are we good? Let me quickly recap. We have pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. Who's their nerve supply? Median nerve. What are they doing? They are bringing some kind of flexion. Where? They are crossing a joint at my wrist joint. So they are flexors. Are we good? Easy. You need not to memorize in a big way. Okay, guys. So now these are further details, base of 5th and base of 6th and blah, blah things. Now, who's this artery? Look at it again. An artery, brachial artery, when it reaches to the head and neck of the radius, it divides. It divides in two. Radial is visible. Ulnar is going inside. I cannot see it, but I can see them dividing at one place. So this radial artery, when you visit your physician, nurse will check your pulse on this radial artery. She always check your pulse, and that pulse is being checked on the radial artery, not on ulnar artery. You can see yourself, ulnar artery is deep. It's sandwiched between the muscles, but this radial artery is sitting on a bone. So it's easily palpable. The term used here, palpable. You cannot see it. Can you see it in your hand? No. But you can feel it. You can palpate it. And if you are relaxed, you put your digits, you can see something is bouncing back to your digits. That's your pulse. And then you take a watch, you can count on it. Are we good? Okay, guys. Now this is radial and ulnar artery, branches of, I will not say branches of, continuation of my brachial artery. And now you can see that it become visible. For a period, it was invisible. Now it become visible between certain structures. Guys, you need to be good with that. Ulnar artery is medial to what and lateral to what? Are very commonly asked questions, MCQ questions. Be careful. Don't ask me at the end what is important. This is, I'm telling you, it is important. Okay. So now you can see the ulnar artery. Now there are something more is visible to you. A nerve is being shown up here. Ulnar nerve. We have seen it. It's passing behind my medial epicondyle. And you can see it's just going by the side of my ulnar artery. Can you see that? Ulnar nerve. Now, if I have an injury, if I hit my elbow on a surface, ulnar nerve is directly under the skin. So I have some kind of, and nerve injuries are concussion. The term concussion, tapping, some severe thing, and then you have an electrocuted type of sensation. So this is what, and this we also called is what? Golfer elbow. In certain condition, it got inflamed. And the golf players, they use these flexors a lot. If anybody sitting here have played or listening to me have played golf, will be knowing that. And we'll be using two terms. Medial epicondyle, injuries related to that. Golfer elbow. Injuries related to the lateral epicondyle, tennis elbow. So this golfer elbow, tennis elbow, commonly used terms. And they are because of what? My common extensor or attachment is where? With the lateral epicondyle. Common flexor is with the medial epicondyle. Please connect. I told you, a complex subject we divide in cues, and these cues have been sequenced. This is a sequencing. And if it goes like that in your memory, in your working memory, it will convert into a long-term memory. A short-term memory into cues, sequencing, working memory, long-term memory. You revise and revise, it will stay there. Okay, so now these are the actions produced by these superficial layer muscles. Are we good? Okay, going further. Now this is same anterior compartment, intermediate group. Only one muscle. Its nerve is median nerve. And that big muscle, you can see it's not only coming from my common flexor side, it also sharing from other places. Now if you have to learn all those things, that is called origin. But what I'm using the term, common flexor and nearby bones from radius ulna. But I'm not giving you specific points. If I give you specific points, that is called origin. But this is proximal attachment. And then what does it? What it does, it comes down and splits 4 digits into 4. And before attaching, distally, everyone further divides. This is my flexor digitorum superficialis. Means I have someone deep also. So flexor digitorum superficialis working at this joint. This is the action. I know it, my flexor digitorum superficialis is working, is okay. And my median nerve is okay if I'm able to do it. If I cannot do it, it means I don't have either flexor digitorum superficialis or my median nerve is not working. So you can simply check and test each and everything. You don't need a lab all the time with you. Are we good? So now, flexor digitorum superficialis. We talk about this artery. We are good with that. Are we? This is the brachial artery who's becoming radial. And then it was further showing us its ulnar part. But still it's not visible to me because now I can see that it is under flexor digitorum superficialis. It was under the superficial layer of muscles. What was the superficial layer of muscles? Pronator teres, flexor carpi radialis, femoris longus, flexor carpi ulnaris. First layer. Second layer, flexor digitorum superficialis. Going to digits. Bringing what? Flexion at, it crosses the joint, flexion at the wrist, flexion at my digits. What level? We'll be talking about. So we can see that ulnar artery and radial artery. And you can see that it's emerging down. It's visible to us. And there is the ulnar nerve, median nerve, all of them has been shown. Can you see that median nerve was in the middle? Now it is moving laterally. Are we good? Now this is what my ulnar artery. Now these are the actions of flexor digitorum superficialis. Guys, this I'm using these FDS and FDP for short, but don't use in the exam. Some people don't understand. You may not be graded. Be careful with abbreviations. Now, are we good with this image? Any issue? Okay. So let's go now. So we have talked about superficial layer. We talk about intermediate layer. Now we are talking about deep layer. So deep layer, their nerve is not median nerve. Anterior interosseous nerve. Same like posterior interosseous nerve. So this anterior interosseous nerve is a deep branch of my median nerve. And posterior interosseous nerve was a deep branch of my radial nerve. Are we clear? Why we call it anterior? Because it lives anterior to interosseous membrane. So now, a quadrangular muscle having 4 angles. This muscle is pronator quadratus on the basis of the action and appearance. This has been classified. Its action is a pronator. And it has 4 angles. So we call it pronator quadratus muscle. And its nerve supply is anterior interosseous nerve, which is a deep branch of median nerve. Now let's talk about the arteries and nerves in my forearm before going to the detail. We know about this. We are watching it continuously. It's coming and hiding. This is my ulnar artery. Everybody should be very clear that ulnar artery is under superficial layer, under intermediate layer. So now you're looking at very clearly both of them. Now what happens? Ulnar artery, it gives a branch which passes between my radius and ulna and is going towards the extensor side. That branch should have a name. We call it common interosseous artery. Common interosseous artery. This is where in the deepest compartment of the forearm. Common interosseous artery. You can see that it gives a branch which goes anterior to the interosseous membrane. We call it anterior interosseous artery. And a branch which goes posterior to it. We'll be calling that as posterior interosseous artery. Now please don't mix artery and nerve. My ulnar artery gives common interosseous. That become anterior interosseous, supplying the deep structures present in my anterior compartment of the forearm, and its posterior interosseous artery supplying the structure present on the extensor compartment of my forearm. Are we good? So they are coming from where? From ulnar artery. Radial artery is just superficial because now ulnar artery is taking the main load. Are we good with that? So now you're looking at the median nerve, you're looking at its anterior interosseous branch. Are we good? You can see the ulnar nerve, how it crosses the medial epicondyle. Now I'm showing you these tendons. These tendons are what? Flexor digitorum superficialis. And each tendon was splitted. Why it was splitted? Because it has to give way to someone. Who has to go forward? Who's that? So these are the function of my pronator quadratus muscle. And then this is that huge muscle. That is my flexor digitorum profundus. In my intermediate layer, it was flexor digitorum superficialis. So flexor digitorum profundus is the one of the deepest muscle, and that is going to my distal. Look at it. This action, it tells me that my flexor digitorum profundus is working, if I can do this. So this brings a strong flexion at this level. Can you see that? So that shows my flexor digitorum profundus is working. So flexor digitorum superficialis. There are other, these ulnaris and radialis. Superficialis, profundus. So you can check each and every muscle by just doing your hand. You don't need any rocket science. Are we clear about it? Now this flexor digitorum profundus is a deep muscle. Half of it gets its supply from the deep branch of median nerve. Half of it is supplied by ulnar nerve. You remember when we were talking that compartment, I showed you digit 4 and 5. So this muscle has double supply. Half of this muscle is supplied by median nerve. Another half of this muscle is supplied by ulnar nerve. And guys, any structure, any muscle who is little different from others, that makes it very important and very critical for your assessment part. So this is different. And digit 2 and 3, median nerve. 4 and 5, ulnar nerve. Are we good? Any questions so far? And my superficialis was splitting because it has to give way to the tendon of profundus. So now I have another flexor. That controls my thumb. First digit, we call it pollicis. Flexor, pollicis longus. That brings flexion at my first digit, at my thumb. This muscle is flexor pollicis longus. Let's recap. Superficial layer, pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. Intermediate layer, flexor digitorum superficialis. Deep layer, pronator quadratus, flexor digitorum profundus, flexor pollicis longus. So altogether, how many muscles we have learned? 4, 5, and 3, 8 muscles. Are we good? So that completes my flexor compartment muscles of the forearm. Story doesn't complete here. Yes, quickly.
Where can we find the brachioradialis muscle?
Brachioradialis, I told you, this is the one who lives with the extensors. When we'll be talking about extensor, you can see him. Not here.
The deep branch of ulnar artery is commonly trunnius artery.
Yeah. Okay, guys. So now, this is showing you how it's been attached. Now this is a concept. I'll be revising it. So this is at my digit level. So this is the extensor group. One tendon, one extensor. And we talk about flexor digitorum profundus and look at flexor digitorum superficialis. It splits and the profundus tendon goes around. So can you hear when you move your hand, can you hear any sound? You never. So we have special type of sleeves. These are called flexor synovial sheets. And they are covering these tendons and they are lubricated inside and they facilitate these movements and they have been anchored with our digits. You can see that how they are anchored. I'm going fast on this slide because I'll be doing it again. I'm developing a little bit idea in your mind. We call it schema. Now, quick recap. We talk about all these. This is all the nerves and vessels. We've been through all of them. This is what you're looking at, the arteries. And this is the angiogram. What is angiogram? we inject a contrast in the arteries and then we take x-rays, a sequence of x-rays. And now this whole artery and its branches are visualized. So if you are expecting, if you are suspecting any blockade or any problem, so we can perform this study. This is called angiogram. Now, so now summarize, we already summarized it. I don't see anything in this slide. We have talked about it already. We know about this nerve. Now this is a very important concept. I don't think I have 2 minutes. I will stop here. Simply let me say that this is called carpal tunnel syndrome. We have a tunnel form, where you are wearing your bracelets or friendship bands or your watch or anything. So there, these tendons to be placed in their location. There is a fibrous band which keeps everything in its position. Now there are certain problems which are associated to that. We'll be talking about that. So next session, come ready, come prepared with carpal tunnel syndrome. Guys, this is really important and it affects a lot of us. Okay, if it goes in problem, it creates a lot of problems, and mostly the women are affected a lot as compared to the males. Any question? Any question emerging? Can you see any in the chat box? Come quickly because Paul will be there. He's waiting for us.
Zoom.
What do you want?
Zoom.
Zoom? This is Zoom? No. What do you want? Tell me.
The chats for the meeting.
The chat for the meeting will be here. Make it big. Let me close it. This is your. This will come from here. Guys, can you help us from your phone? Anybody? Rather than wasting time.
Because they asked to the panelists, that's why.
Actually, this
Where?
is different because it's a different type of organization. There is no more here. It's a different type of window here. It's very different. You can use your phone. You can take someone's.
The questions, they usually send it to the panelists.
I know.
To put myself as a panelist. So you only see it here.
I don't see them here. No.
Yeah.
No. You can use anyone's. Yeah, there is a chat. Chat is not opening with me. Or we can go to the home.
Back to meeting.
Back to meeting. No, it's not.
Or click on them.
Doctor, someone is asking,
Hmm.
the ulnar artery lateral to Flexor carpi ulnaris and medial to ulnaris longus.
Ulnar artery, you have to see it in both the ends, and then you can understand. And we'll be talking about that. I have to have an image in front of me, then only I can talk about that. But obviously, ulnar artery is medial to that. What else? Is there any further question?
What is the fine pruning?
What is the prime pronator? Prime pronator is pronator quadratus. Actually, there is no clear-cut demarcation between pronator teres and quadratus, but quadratus is more stronger. And pronator quadratus even help you that your radius and ulna should not go apart. You're doing push-ups. So this muscle keeps the two bones together. It's not only pronates, but it also keeps the radius and ulna together at the distal end.
Someone's asking, why does the anterior compartment pronate?
It's not. It's a joint action because we have pronator living on this side and supinators are on the other side. So these muscles, they are located on this side. So if you want to go into the biomechanics, then probably we need to talk in more detail about that.
Okay, someone's asking, do we need to know the arteries that contribute to the muscle or just
You need to know about these arteries are located here. And let me tell you, the deep structures of my forearm, their blood supply is from anterior intraosseous artery, which is a branch of ulnar artery. If you know this much, enough. We are not asking name which artery goes and supply which muscle. No, not individually. We'll be asking in the format of a group. Same is for the posterior compartment of the forearm. I think you can open chat from there.
I can't control. Yeah.
Can you get it? Chat. Any other thing? It is not coming up here.
On the right?
There is no more here.
doctor, someone's asking, what happens when you crack your knuckle?
What happened?
When you crack your knuckle, what happens?
There's nothing happen. You know, cracking knuckle when you're making sound. I think leave this question for the hand. We'll be having a full lecture, 2 hours, lecture number 15. I'll be spending good time for the hand.
Below the Wi-Fi?
No, Mac has a very different organization here.
Oh, this one?
No, not this one.
This one. Chat.
No, I have it.
I think you have to stop.
Yeah, I have it. Now I think Dr. Paul is
If
waiting.
you want to stop the recording.
Okay, I can stop the recording. Don't worry.
Doctor, you want to see the chat?
Yeah, I got the
You
chat.
can see it.
We saw it. So guys, we are done. So now stop video. Yes, I did.
You can just click end.
Yeah. And for all.